Folks could please get their seats. We can get started. Well, good afternoon, everyone. All right, that's week. It's National Public Health Week. Let's try that one more time. Good afternoon. That's much better. Let me, of course, welcome you all here to National Public Health Week 2016. I think we have an amazing week for you. Just wanted to tell you a little bit about the American Public Health Association. We've really felt that it was important that we challenge the nation to become the healthiest nation in a generation. And we think of that generation being 2030 being a very important time frame because of a couple things. For those of you who are old like me, it is kind of the end of the baby boomer generation going into seniorhood. But it's also the adolescence of Generation X. So it's really kind of this dual generational time period where we think that the next several years, there's an enormous opportunity over the next 15 years to make a big difference in the health of our nation. As you know, if you get sick, this is the place to be. And yet, we're not the healthiest nation, and we spend twice as much as the other industrialized nations, and we die sooner. And we know that we can make a big difference here. There's a lot of evidence. We know the science, and so that's very important. So this is the strategic map of the American Public Health Association. You'll notice that it points out that our central challenge is to try to work to help to create the healthiest nation. And the point I want to also make is that you don't do this alone. So there are many of you here in the room, and those of you who are reviewing this on a remote recognize that this is something that's important and that we can all partner and do this. We do this a lot by engaging the general public, policymakers, and a whole range of partners through education, good communication, and solid advocacy, which we think will make a big difference. We also want to announce today that we want to get people to do something really simple as a start. And so we have this 1 billion steps challenge. And this is the idea of taking small steps for big change. We're encouraging people to be part of something we call Generation Public Health. Generation Public Health is those people that have made a commitment to trying to become part of the healthiest nation. And if you go to this website that's here, you can log in. And the idea is to log in your steps weekly. Again, it's one small thing that people can do individually, both to try to improve their health and then ultimately improve the health of the nation. So if you also, to join Generation Public Health, you go to APHA.org/2030 as a way of being part of joining Generation Public Health. And we think that's another action step that people can do. So sign up for the Billion Steps campaign. Number two, join Generation Public Health, I think are the first two things that each and every citizen, immigrant, individual that walks through our borders ought to do to try to be part of this healthy generation. This is a remarkable time, I think, for our nation as we begin to think of the consolidation of forces of different groups and organizations that are very much interested in improving our health. I think this is an important moment in time. And there are others that also feel this way. So I'd like, hopefully everyone got a copy of this for you to note that we do have a presidential proclamation. I won't sit here and read it, but it is signed by the President of the United States, Barack Obama, and he talks about the importance of National Public Health Week and the importance of the public health community in ensuring us being part of a healthy nation. But in addition, let me see if I can get this up here.
To President Obama.
Here we go.
Hi, I'm Valerie Jarrett, Senior Advisor to President Obama. I wanted to wish you a happy National Public Health Week and thank you for your extraordinary leadership. Public health is fundamental. It's about our families, our environment, and the world we leave behind to our children. It's about our basic belief that we are all in this together, and that we all have a role to play in making this a healthier and more vibrant world. America's public health workers and advocates are central to that work, and we are so proud to have you as our partners. Whether it's expanding health care to 20 million Americans under the Affordable Care Act, or fighting climate change and its disastrous health impacts on our children and generations to come. Whether it's ensuring that every child can reach their full potential and not have their lives taken by gun violence, or coming together to take on viruses such as Zika that have the potential to cause profound impacts, or whether it's simply encouraging each other to live our healthier lives by eating well, exercising, and seeking the preventive care we all need. We all have a role to play. As President Obama has said, America is built on the notion that we are our brother's keeper and our sister's keeper, and that we all have certain obligations to one another. Never is that idea truer than when ensuring the public health of the world our children will live in long after we're gone. That's what this work is all about. So thanks for leading the charge and for helping move our communities forward.
So I want to just thank Ms. Jarrett for that kind video introduction for our meeting. As you know, this administration has been a strong supporter of building healthy communities, whether it is the First Lady, who has been leading that movement since they came into office, and of course the President, and Ms. Jarrett, who's been working tirelessly behind the scenes to do this kind of work. Next, I'd like to bring to the podium a good friend of mine for really another important announcement. This is Dr. Garth Graham. Garth is the president of the Kaiser Foundation, and in his role, he is responsible for the foundation's philanthropic work, including its grant-making strategies to improve the health with a particular focus on people from underserved communities. Now, some of you may know of Dr. Graham's previous work when he was the Deputy Assistant Secretary for Health and Minority Health at the U.S. Department of Health and Human Services, where he has just an unmeasurable amount of accomplishments, including his work there on the Affordable Care Act, his work in promoting the REACH grants, his real national work in working throughout the administration and really across sectors within the administration to achieve health equity. He's also a well-known researcher and writer. Folks may or may not know this. He's a cardiologist and an interventional cardiologist, I might add, who, like me, I'm an ER doc, got the bug and got into population health and recognized how important it was to not only be competent at taking care of people one patient at a time, but also looking at ways in which we can improve health by the hundreds, thousands, and millions. He holds a medical degree from the Yale School of Medicine and a master's in public health degree also from Yale. He is completed his clinical training at the Massachusetts General Hospital and trained, I believe, in Johns Hopkins in cardiology. He is board certified in internal medicine, cardiology, and interventional cardiology. He also serves as an associate professor of medicine at the University of Connecticut School of Medicine. So, Garth, Dr. Graham, I'd love for you to come up and make a very important announcement.
Thank you, Dr. Benjamin. I always try and get those introductions on tape for my mom to see, because she's like, still got to do the dishes. Okay, so firstly, speaking of my mom, I always start off everything I do with a word of thanks and praise. And my first thanks is certainly to the APHA folks and all the other folks around the country who've been working tirelessly in the field of public health, trying to move the needle one community at a time, even sometimes one person at a time in terms of trying to make folks healthier. And so I always want to start off by recognizing the work that this organization does, and certainly the work that many of you here in the audience and who are watching my live stream, some of the things that you've been doing for years to fight the good fight on the front lines. I also want to recognize a couple of people who are here with us today and folks who within the public health community have not only done an immeasurable service in terms of what they've been able to accomplish, but certainly also for communities and making sure that they bring the issue of equity and social justice to the very front and center. And whenever I see Kamara Jones, I always want to speak right before her, because going after Kamara means that things can only go downhill for you then. But Kamara Jones, who has served as a mentor to many of us in terms of what we see and aspire to be, in terms of making sure that we have an impact in the community. Look at folks like Woody Kessel, who's here, and Woody and the stuff that he has done as a public health service officer and assistant surgeon general, and making our world healthier and recognizing a lot that he has done. I look in the front row and I see Lee Fisher, who's a former lieutenant governor of the state of Ohio, and who has gone on to do all kinds of things to try and make sure that folks, not just in Cleveland, but across the whole state of Ohio, continue to do a lot of healthy behaviors to make sure that they make that state healthier. And all of the folks here that one by one or collectively are working to make a difference. Getting off that soapbox now and going to why George has wanted me to speak to you all here today. So last year, we got together, the folks from the American Public Health Association, a lot of public health partners working with my folks and other folks across the country. And we really started to think about what is it that we could do to move this needle around social determinants of health. And we know that there are a lot of activities going around the country. And I think recognizing, as I said to you before, all of the things that are going on in the front line and the trenches, and how can we support much of the work that the public health folks are doing within either their local public health communities or other forms of leadership at the city and county level. And we came up with this idea of having the Healthiest Cities and Counties Challenge. And the challenge is really a partnership between the Aetna Foundation, the American Public Health Association, and NACO, the National Association of Counties, to work to incentivize counties and cities and tribal communities to make healthier steps around, particularly around social determinants of health. And Dr. Benjamin mentioned my work as a physician. And one of the things we always realize as physicians is when you see somebody in your office or you see them in a procedural room, you're only seeing the tip of the iceberg of that person's lives. There's so many things that have gone into what brought them there to see you there today. There are challenges they may face in terms of just simple housing. There's challenges they may face in terms of transportation. There's challenges that individual might have faced in terms of their exposures. We never thought that we would be speaking at the national level about things like healthy water and making sure that everyone has access to clean water in our country and clean air and those kinds of things. And we thought about how do we incentivize local, as I said, county officials as well as cities and folks working in tribal communities to be able to achieve those goals. And we came up with this idea working with Lee and all the other folks who were working around the table around the Healthiest Cities and Counties Challenge. And today we want to announce that we're opening up that challenge to all the cities and counties and tribal communities across the nation. And the idea here is to reward folks who make progress around not just healthy behaviors, but some of the social determinants of health. And some of those priorities for us are looking at things like safety. How do we make sure that people feel safe in their own community, that when they step out their door, that that community belongs to them and that they feel at home in their community? And making sure that, as I said before, the third area around a healthy environment in terms of making sure that water and air and sanitation is also healthy. So two other particular areas, the built environment, and folks are very familiar with things like walkability, bikeability, and making sure that people have access to things that can make them particularly healthy. There are the two areas that we also wanted to emphasize that are particularly important for our communities. That is an economic viability, to make sure that there is a living wage that helps to sustain individuals, families, and communities, and back that up with education and infrastructure around high school graduation rates and all of those things that go into being. So the litany of things I just said to you are the kinds of things that we will be rewarding people for in terms of making progress over a 2-year time period, again, looking at cities, counties, and tribal communities as well. And that's part of what we're trying to do with this Healthy Cities and Community Challenge. We'll put together an expert advisory group, and if you go to the website, you'll see all kind of big and impressive names that I am honored to be associated with. But more importantly, what we're trying to do is to go across the country and incentivize folks to be able to make changes and reward them for changes as they do these kinds of things. So as we were putting this together, we had some cities we like to term early adopters, meaning that they were so excited that they jumped on board early. And I want to announce some of those cities here with you this afternoon. So we're seeing some amazing work being done or being proposed to be done in Cleveland, Ohio, and what they're trying to do around moving the needle on health equity and improving disparities. Kansas City, Missouri, New Haven, Connecticut, San Diego County, California, Tulsa, Oklahoma, as well as the folks who are working in Durham and Cabarrus County in North Carolina. These folks we are identifying as our early innovators and giving them a grant to be able to convene and do planning as they try and move towards making their communities healthier. We're also opening up the RFP to all the communities across the country. And what we hope to do is to award 30 to 50 cities and counties with this convening grant to then be able to work over the next 2 years around making some sustainable changes and sustainable progress around some of those areas that I said to you earlier. So, here's a slide of those esteemed people I alluded to before. But suffice to say that this is an evidence-based set of activities and making sure that we pay attention to not just the public health science, but also the social sciences in being able to move forward. So a wonderful partnership. We're happy to recognize certainly APHA's leadership in being able to move foundations like ours and others to be able to move on things like this. And we also want to recognize all of the folks, like I said before, who have been working on the front lines of public health for a number of years in being able to recognize the importance of social determinants of health. George, hopefully I didn't miss anything, which I often do. But we encourage you to help us spread the word, make sure that your city or county, especially for the folks who are watching on live stream, folks get engaged in this particular effort and allow us to make social determinants of health not just an esoteric thing that we strive towards, but a very concrete goal, and making sure that we reward ourselves appropriately for doing that.
Thank you. Okay. Well, thank you very much, Dr. Graham. I'm going to introduce the other two members of our panel. So we're going to have a panel discussion. The first person I'd like to bring up, Dr. Graham talked a little bit about, but this is Dr. Kamara Jones. Dr. Jones is the president of the American Public Health Association. She's a senior fellow at the Satcher Health Leadership Institute and Cardiovascular Research Institute at the Morehouse School of Medicine. She is a family physician and an epidemiologist whose work focuses on the impacts of racism on the health and well-being of the nation. As you know, racism and discrimination are certainly components of the social determinants of health. She seeks to broaden the national health debate to include not only universal access to high-quality health care, but also raise attention to the social determinants of health, which also include, of course, things like transportation and education and poverty, and other aspects of equity. As a methodologist, she's developed new methods for comparing full distributions of data rather than simply comparing means or proportions in order to investigate population-level risk factors and propose population-level interventions. As a teacher, and this doctor is a real teacher, she uses allegories on race and racism to illustrate topics that are otherwise difficult for many people to understand. She talks about hoping that her work will help initiate a national conversation on racism and then ultimately result in a national campaign in our nation against racism. I've known Dr. Jones for many, many years. She is one of the most incredibly well-trained folks that I know. From her years training at Stanford University, Hopkins University, and her time as a medical epidemiologist at the U.S. Center for Disease Control and Prevention, Dr. Jones has really been the voice of our nation on health equity for many years. And so I'm going to ask her to come up and join us on the panel. If you give her a great round of applause, please. I'd also like to introduce Margaret Linscott. She's a sophomore at James Madison University. She is our 2014 National Youth Advocate of the Year and sits on the board of the Campaign for Tobacco-Free Kids. She joined her county's chapter at the statewide Students Working Against Tobacco, known as SWAT program, as a freshman, where she first learned about the devastating effects of tobacco when her grandmother died of a tobacco-related disease. To help reduce tobacco use among her peers, she successfully worked to pass a countywide K-12 comprehensive tobacco policy that bans tobacco use on social grounds and at school-sanctioned events off campus. She has also advocated for Florida counties to pass resolutions supporting a ban on candy-flavored tobacco. She's learned to tap into the power of social media to promote Florida's new Not a Replacement tobacco prevention campaign, where youth are encouraged to send selfie statements to tobacco companies, photos of themselves with handwritten signs telling Big Tobacco that they are not replacement smokers, but individuals. Since its inception, Not a Replacement has been featured in 17 magazine, the Huffington Post, and Chelsea Clinton's book, It's Your World. In 2014, she was named the Campaign for Tobacco-Free Kids National Youth Advocate of the Year. And since then, she has worked with various tobacco prevention groups across North America to spread the message of the power of the youth voice and work with the Campaign for Tobacco-Free Kids to implement the Not a Replacement campaign on an international level. Currently, she is attending James Madison University to earn her degree in public policy and speaks at youth advocacy conferences around the country. And I can't think of anyone who could not help but lead us into the 2030s, but Ms. Maggie Linscott. Maggie, if you come up and join us. I have to take the far seat. All right. I wanted to start this conversation by just starting some questions from our panelists. And this is for the whole panel. Obviously, we worked very hard to get the Affordable Care Act in place. And now that we have a record number of people with health insurance coverage, I think we can now really zero in on what keeps our communities healthy. How can we make the shift from the national dialogue on health insurance coverage to a dialogue on creating healthy opportunities for all of us? Let me start with you, Dr. Jones.
Well, thank you for that question. And I think there is a lot to celebrate in terms of increasing access to health insurance, although we are not there. And I actually live in the state of Georgia, where we have not expanded Medicaid, which was a key part of the Affordable Care Act. And there are 17, I think, still states, most in the South, where even that part hasn't been done. But I often try to illustrate different levels of health intervention with a cliff analogy. So if I might just very quickly draw in the air an image, first of all, of somebody just walking along, and then whoops, boom, they fall off the edge of the cliff of good health, in fact. And if that were you or somebody in your family, you'd be delighted to find an ambulance there at the bottom of the cliff to speed you on to care, right? That's one level of health intervention. But if we were interested in public health, community health, population health, if this were National Public Health Week that we were launching, we might well ask ourselves, as you just did, what else could we put in place besides just stationing lots of ambulances at the bottom of the cliff? So one thing we could put is a net to keep people from getting crunched at the bottom, even if they've fallen. But nets, as good an idea as that is, have holes in them. Some people might fall through the cracks. We could even make that a trampoline halfway down. No holes in a trampoline. But even if we had a trampoline halfway down that cliff, we might find ourselves with lots of people just bouncing up and down at half functionality, not able to get back to the top of the cliff. So we could say, oh yes, of course, we need a fence at the edge of the cliff to keep people from falling in the first place. But even with the fence, it's going to have to be a strong fence if there's a lot of population pressure against it. So what else could we do as a health intervention? We could move the population away from the edge of the cliff. So clearly I've talked about medical care and tertiary prevention being preventing the complications from disease that's already manifest. I've talked about secondary prevention, safety net programs, early detection screening. I've talked about primary prevention, keeping things from happening in the first place, like immunizations. And I've also talked about addressing the social determinants of health. I'm so encouraged by this Healthy Cities and Counties Challenge. You know, that's about addressing the determinants of health and illness that are outside of the individual, right? Beyond our individual genes, beyond our behaviors. So poverty, housing, transportation, agriculture, education, all of that. But even that cliff, when I've talked about these 4 levels of health intervention, all of them very important, even that cliff hasn't talked about how health disparities arise. And when you think about health disparities arising on at least 3 levels, differences in quality of care received within the healthcare system, the Institute of Medicine in 2002 released its unequal treatment report, documenting at that time hundreds of studies, you know, that were saying, you know, if you come in with chest pain, how vigorously your chest pain would be addressed depends on your race, or how much pain medication you would get if you walked into an emergency department with a long bone fracture would depend on your ethnicity or your race. So there's differences in quality of care, but then of course there's also differences in access to care. We're trying, you know, against resistance unbelievably to increase that, but we all recognize in this room that health is not created within the health sector. So there's a 3rd level at which health disparities arise, differences in the quality of our lives, in our life opportunities, exposures, and stresses. So when you think about those 3 levels at which health disparities arise, and you think about the cliff that I've just drawn, actually, I don't need to be talking about a flat 2-dimensional cliff. Actually, we are dealing with a 3-dimensional cliff. And at some parts of the cliff, there might be an ambulance there, but it might have a flat tire. So it might be slow or go off in the wrong direction, or maybe there's no ambulance, nor net, nor fence, and usually at those parts of the cliff, the population is being pushed closer to the edge. So I would like to expand, in terms of the Healthy Cities and Counties Challenge, not only do we need to be about moving the population away from the edge of the cliff, but we also need to be asking what is creating 3-dimensionality in the cliff, what is keeping it that way, and how do we address what I describe not as the social determinants of health, but the social determinants of equity. systems of power that can distribute resources and populations. Because usually at those parts of the cliff where you don't have ambulance, net, or fence, the population is being pushed closer to the edge. How do we address those things like racism, sexism, heterosexism, economic systems like capitalism and the like? And actually, I'll close with this. In my presidential initiative as APHA president, I announced that we're going to launch a national campaign against racism, not because APHA by itself can undo this system, not that I, in 1 year as president, can do that, but to do some agenda setting and to invite partners and communities to name racism, to ask how is racism operating here, and to organize and strategize to act. So I think that is the opportunity. And I'd love to talk about that more. But.
Thank you. Ms. Lynn Scott.
First off, I'd like to say that it's an absolute honor to be sitting at this table. I think it's safe to say that among the four of us sitting at this table, when I get home tonight, I might be the only one to study for a test. So it's an absolute honor to be here. I've been in tobacco control. I'm a youth advocate for about 5 years now, and I've really seen the impact that it's had on my peers and my family. Tobacco use takes approximately 400,000 American lives each year. However, we know how to reduce tobacco use, how to stop it in its tracks. Multiple research studies have found that we know how to reduce it, from tobacco taxes to smoke-free workplaces to media campaigns or even evidence-based cessation models. And so I'd like to talk briefly about mass media public education campaigns, because I think it's really important in promoting public health. The CDC's Tips from Former Smokers campaign, among those, approximately 1.6 million people who saw that campaign made quit attempts, and nearly 100,000 people quit permanently. And I think that really has something to say about the power of public education campaigns, mass media campaigns, when it comes to talking about public health and trying to keep people from getting sick. Just in terms of the tobacco control movement, the tobacco industry actually spends about $8.8 billion each year to market and advertise their products. So in that place, there's almost this vacuum if we don't have an answer to that, if we don't have some sort of educational piece to get people to quit or to educate them about the harmful effects of those products. But in general, mass media campaigns like the CDC's, I think, really need to be replicated, not just with tobacco use, but with a variety of other health factors. And I think that it can reduce unhealthy behaviors, health behaviors, and really help to promote more healthy behaviors. So these mass media campaigns, I think, are really that next step into really trying to promote healthy behaviors.
Thank you. Dr. Graham.
So I'll take a page from what Kamara just said and add a little thing about understanding the importance of societal barriers. And the other day I was asked, what is the one intervention that I think would make any particular community, particularly low-income communities, healthier? And I, as a doctor, I actually think it's education. And the reason I think it's education is because education offers people opportunities to make them economically viable, and all these different kinds of things to realize their full potential. And that allows them to live not necessarily a disease-free life, but a healthier life. And I think there's a difference between not having a disease and being optimized in terms of your health. When I was hearing Kamara's story, I was just thinking of my own even personal life story and how early on in life, our mom said, okay, it's the third time talking about her today. My mother said that education was going to be our key out. It turns out she was right. And I think that education allows you to be able to do all the kinds of things you want to be able to do in life, like sit here and have this conversation about a national agenda that you've been a part of in different kinds of ways. So why do I go to your answer when you ask, what is the next step beyond the Affordable Care Act? I do think it is referring to the things that both of you said. It's just, how do you make a community more resilient in terms of when messaging, negative messaging might try to have them do activities that are bad for their health. and the antidote for that is education. It might not necessarily be the formal education that I was alluding to before, but it is education in a different format. So I think that the concepts of social determinants of health are particularly important, as we were kind of alluding to before. But if I was going to pick one kind of quiver and arrow to deal with the challenges beyond where we are today, I would say it is education opportunity, which leads to economic viability, which leads to people being able to understand the world better, and more importantly, allows them to have opportunities to have impact.
So I know you talked about structural racism in education and tobacco, and the importance of mass media. What are some of the other social determinants of health? Now, we've got the Healthy Cities Counties Challenge going on. I know that Aetna, you also have another community challenge as well, in which you've got grant dollars going out the door for certain determinants and indicators. Can you talk about some of that work, and particularly from a social determinants perspective, what you're trying to hope to achieve through your work?
Yeah, and so, I always, coming from government and then academics and not being here, I always think that the dollars is just a secondary to what you can do to empower people. And so if you can empower them with $1, that's great. If you can empower them with $50, that's great. If you can empower them with $1 million, that's even better. But the real thing that we're trying to get to with all of our investments and our activities is how do we empower people to make better decisions and to live healthier lives. And to do that, you have to make the default easier, and you have to remove all the structural barriers that people face, particularly folks from poor and low-income communities. And so I think all of our grant making is aimed with the lens of equity and with the vision of empowerment and being able to deal with it. Now, the problem is, as Kamara alluded to, these problems are very deep. And even when I think about my own life story and all the challenges we've faced, there are things that go to a different depth that you need other things to happen. And this goes back to even when we started the concept of the challenge and how we even came up with this idea and all the other things that different partners have been bringing to the table, including Lee and the leadership of the Focus CEOs for Cities, is this idea of being multi-sectoral. And so to get to the depth of the challenge, you do need to look at transportation, you do need to look at housing, you do need to look at education, which I was alluding to before, and you do need to look at all of these sectors in a multi-faceted approach, and to use the public health term, health in all policies approach is probably the best way. So that's how I view our attempts at a solution. But our attempts have a lot to do with hopefully inspiring people to be able to do other things.
Thank you. Ms. Linscott, can you talk a little bit about your experience on campus and in terms of the fight against big tobacco and some of your experiences there, using tobacco as a social determinant?
Right, yeah. So tobacco is definitely can be a social determinant, but there's also other factors that play into it, if you're more likely to use tobacco. The LGBTQ plus community has a much higher use of tobacco than the general population, and part of this can be attributed to the fact that they're directly marketed to by the tobacco industry. But on campus, and actually, if I could go even further back to when I was in elementary school, I actually lived in a military family, so I've switched schools approximately 8 times in a variety of different states. And so what this has done for me is I've been able to see how different schools operate in different states. So I went to one school where they had morning yoga and morning stretches every day before class, and really nutritional lunches. And then the next school I went to didn't have any of that, and we had chips and soda. Those were the only things that we could get. And so that type of environment that was cultivated, those 2 different environments, really played a big impact on how the students made healthy decisions and how they made unhealthy decisions even. And so the school with the unhealthy food and the lack of health education, you saw a lot more of those students abusing substances or using tobacco. And so I think it's really important to realize that education is a really big factor when it comes to assessing social determinants of health. And then another one, obviously, on campus, just fast forwarding. On campus, you know, my generation loves the internet. They like the memes, they like social media, and that actually it can be a huge factor because it can either cultivate an environment to make healthy decisions or it can do the opposite. And so assessing how that culture, how that internet culture plays an impact into tobacco use or even other behaviors is really important as we moved towards 2030.
Dr. Jones?
Well, I've been scribbling lots of things. I'm going to put it in a thing because I think it's so interesting that you talked about the different schools. And as you well know, it doesn't just so happen that one school is one way and another school is another way. There are lots of reasons, and sometimes we don't ask that deeper why question. So we have gone to understand that we have to ask why some people put certain things in their mouths and other people put other things in their mouths. And so we say, oh, it has to do with the context, the social determinants. But why do some people find themselves going to schools with yoga and healthy lunches, and other people find themselves going to school with soda pop and potato chips? And so we have to keep asking a why question. And when you get to that second level of why question, that's when you get to how are the decisions made. So who's at the table and who's not? What's on the agenda, what's not? All of these mechanisms, you know, what are the policies? You know, what is the how of decision making? What are the practices and norms, the unwritten how of decision making? What are the values? What are the why? Do the people who are making the decisions care about this community, or they say, oh, it doesn't matter, these are not my children, you know? Because we do think in terms of my children and your children, not our children. But if we're really going to make progress on the healthiest nation by 2030, the healthiest nation in the children, we need to know that these are all our children. So I just wanted to pick up and say that there are, you know, I've talked about racism and sexism and all. There are many systems of structured inequity going on in our society that are the why. They are the why of how resources and opportunities and risk are distributed. The one that I spent most of my life's work on is racism, so I'll just offer up a definition of racism that we can then generalize to be a definition of any of these systems of structured inequity. Because when I talk about racism, I'm not talking about, you know, an individual character flaw or a personal moral failing or even a psychiatric illness, as some people have suggested. I'm talking about a system of power. It's a system of power that structures opportunity and that assigns value based on so-called race. And the impacts are that it unfairly disadvantages some individuals and communities, those kids who are growing up in the school with the potato chips and soda. It unfairly advantages other individuals and communities, those that are growing up with the yoga and the healthy lunches. But even at the same time, it's sapping the strength of our whole society through the waste of human resources. Because when we allow some of our kids to grow up in unhealthy environments, then that is sapping the strength of all of us. That same definition of racism can actually be a definition of any system of structured inequity. So what is sexism? That's a system of structuring opportunity and assigning value based on gender that unfairly disadvantages some, unfairly advantages others, and saps the strength of the whole society through the waste of human resources. Of course, there are many systems of inequity going on in our society today. They're intersecting in communities, they're intersecting in people. So we acknowledge all of them, you know, language, nationality, obesity, you know, body weight, rural, or, you know, urban, all of these things going on. But I do have to say that as president of APHA, I think it is urgent for us to address race as the axis of inequity and racism as the system, because that one is foundational in our nation's history, and yet so many people are in denial of its continued existence and profound impacts on the health and well-being of the nation. And what we learn from addressing racism will help us address all of these other isms so that we can have the healthiest nation in one generation, because if we're fractionated and like, I'm okay, so I don't worry about you, we will never get there.
Thank you. Let me remind folks that are watching us that they can submit questions on Twitter by hashtag pound NPHW. That's questions on Twitter by hashtag, that's pound NPHW. So we also make a big deal about the fact that we're not the healthiest nation. And so compared to other high-income nations in the world, you know, they must have some strategies that we're not using. You know, what are we not doing right, quote unquote, so that we're not as competitive as they are from a health perspective. Graham, you've certainly done a fair amount of traveling. What would you say?
That's one way to put it. I read something interesting today, and it was the 3 factors that lead to happiness. And one was having strong friends and families, and then the second was feeling equal and valued. And I want to just pause at that second one because to take Hamara's point around challenges we face around inequities and how that plays out into the health of this country. And it was saying that for the countries in the Scandinavian, geographies that feel that they're the most egalitarian, their levels of happiness is the highest. And it goes back to this concept of how inequities, whether there be health inequities or some of the other challenges that we're trying to deal with around social determinants, et cetera, how that plays out as a country for us and how that plays out in terms of how we interact, build social bonds, and build all the kind of community bonds that make communities healthier. And I would say then that if there is one thing that we should look at in terms of challenging, and again, going back to taking a page from both of you all, is making sure that we connect folks and understand how we break down those challenges around inequities. And so I would say that that is one of the things that, though not necessarily unique to us as a country, I think we face significant challenges around health disparities, and the collective addressing of these health disparities, I think, can potentially move us from where we are right now to where we should be.
Go ahead.
I'd like to follow up. When you said that education is where you would put all of your eggs, that's where I put mine too. Because yes, no, because that is how we invest in our future. But the things that other countries also have is strong social security around children and young families, and we don't have that. So there are other countries that have income gradients, perhaps not as extreme as ours is becoming. But even those that have income gradients, health is not related to income or social class. So in this country, for all groups, health is very much related to your income, education, all of these social class markers. But in some Western European countries, that is not the case, even though you still have some people with cars and some people with bicycles, so that's probably helping them. But what you do have is strong social security, so that when a family has a baby, not only 1 year of paid maternal leave, but paid paternal leave, free, excellent daycare from the earliest ages, free university education, all of these things, which then turn into excellent health. So I think that we need to, if we're serious about becoming the healthiest nation in one generation, first of all, abandon this myth of American exceptionalism and take a good look at what's happening all over the world, right? And try to learn from these other countries, because there's so much to learn. I'll just stop there.
I think part of it too is the policy conscriptions that we have for some things. So we all know, or at least we like to think that we know that the societal issues that we face, but what we disagree on is how we're going to address these through policy. And so specifically talking about our policies in regards to tobacco control policies. Nearly 180 parties are part of the WHO Framework Convention for Tobacco Control. And in this Framework Convention, they have 4 core evidence-based policies that are known to reduce tobacco use. Those are graphic warning labels. Currently, 102 countries around the world have enacted graphic warning labels. The biggest one currently, Australia. They require 75% of the principal side of their package to have a graphic warning. I don't know if you've ever seen the pictures for those labels, but they're quite grotesque. I think they might do the job. And the other 3 core policies are 100% smoke-free policies, bans on tobacco advertising, sponsorship, and promotion, as well as tobacco taxes. Now, Latin American countries and the Caribbean have actually been leaders in 100% smoke-free policies. Currently, we are not really anywhere near getting there on a national level. States have done it, but not on a federal level. So I think we can learn a lot from these countries taking this Framework Convention of Tobacco Control and looking at these policies that other countries have already set into place and realizing that these might be policies that we should be implementing here, and really starting a dialogue about that would be important as well.
May I ask you, did we sign this framework convention?
We signed it, but we did not ratify it, so, yes.
Yeah, it's not been submitted to Congress for ratification by the Congress. But it was signed by the Secretary of Health and Human Services for the U.S., but it just says, like many treaties, has not yet been approved by the Congress. So let's talk about trying to move the ball forward. And, you know, obviously, one of the things I said earlier, I think I've heard in the tenor of everything that everyone said, is that none of us can do it alone. Let's talk about cross-sector partnerships that we might try to do to try to achieve this work. Dr. Graham?
Yeah, so I think, you know, there's cross-sectoral partnerships at a variety of different levels, and the closer you can drive it down to the kind of grassroots community level is the closer folks can see it. So, you know, what we're trying to do with this challenge is certainly, I think, have kind of city and local governments as one particular unit, create cross-collaborations around housing, education, and all the kinds of different things that we articulated here to deal with that unit of social determinant of health. I will say, though, that even, and I also think of sometimes when I'm rounding and looking at patients, and how even when you drive it down to the even patient level, the more the team works together is the better that patient has an outcome of sometimes even just living, much less just making it out of the hospital. But then we have to step it up a little bit and then kind of take that, so I was going from the patient to where we're talking about the community and now backing up to the national level. And I think one of the things that you see, particularly with the partnership we're talking about here today, as well as how, what I think is a vision for the future, is how can we have folks who are leaders in frontline work around public health and public collaboration, major businesses who have a stake in making sure that the health of our communities are particularly important, folks who are leaders in their respective fields and can articulate a vision for what we need to be able to do as a country and create all those kinds of partnerships that are unique at the national level and don't normally kind of fit together were it not for similar passions around making our country healthier. And so I think we need to look at those different kind of collaborations, again, from kind of the treetops of the grassroots, from the 10,000 to the one foot level, and how do we make some of those partnerships unique so that the tailoring and the end goal is both making a nation, a community, and an individual healthier.
But I'm going to challenge us because, you know, we have the National Prevention Strategy, the National Prevention Council, which was actually mandated in the Affordable Care Act, and the Surgeon General convenes the heads of all of the departments, health, you know, but transportation, education, justice, labor, everybody's around the table. And yet, when we try to get them around our health table, we end up with a health product so that when you look at the diagram, the schema thing, you have some core goals, but all of the action steps, all of the strategies are health strategies. And so what we need to do is to either encourage around these same four core principles an education ring or a transportation ring or whatever, because we feel that health is central, but then housing feels that housing is central. And whenever we try in public health to convene people around our health table, they'll come. You know, they'll come, they're happy to come, but the product tends to be still action in the health realm. And I think that there's something lacking about how we're approaching things. I would challenge us in that way.
Or have you seen something that's gotten you excited, either even in a little school to a big community that you say, oh, there's an example of what we can learn?
Oh, boy. The thing that would get me excited would be things to interrupt the, kind of the school to prison pipeline. I think that's a great opportunity for us to all come together, because there you have education, you have health, you have housing, you have all of those things. Have I seen it yet? Not really. Have you?
No, I was hoping you'd give an answer that I could then kind of take and run with, right? I was like, yeah, you're right, Kamara, there you go. But it is a challenge.
Yeah, some questions for the audience. If there are questions from the audience, please line up at the mics. This will be Mike on my left and Mike on my right. While we're doing that, let me ask Ms. Linscott if you could maybe comment. One of the policies that is beginning to be considered around the nation is raising the age for tobacco, the age of 21. Do you have any perspectives on that?
I think unsurprisingly, my perspective would be like, yes, that sounds like a good policy. No, I think, there's been multiple states that are considering it, have considered it, passed that. And I think it's a very, very good first step into really protecting the health of youth. The problem, however, is that, the age right now is 18 for most states, and youth are still getting access to these products. And so this, obviously is a big issue. And I think at least one of the answers, I can't say I know all the answers to it, but I think at least one of the answers is really cultivating the power of the youth voice. So we talked a little bit about partnerships in trying to make 2030 America, have America be the healthiest nation. And I think one way to really do that is to realize that youth have every bit a place at the table as adults do in assessing the health of the nation and trying to promote the health of the nation as well. For, a lot of youth, it's kind of, I don't know, it's a different world than the world of my parents and my grandparents, and it can be a scarier world. And I think it's important that youth recognize that they have power to really promote healthy communities. And so, you talked about a specific example, and even on a small scale, I will say this. I've been to several different conferences, and I've spoken to a lot of really passionate youth advocates, not just about tobacco control, but just about making a difference and trying to change the world in whatever way they can. And I think there's a lot of untapped potential there. There's a lot of people who say that millennials are, what's that word, like lazy, entitled, narcissists, that sort of thing. And I think, it might be true on one level, but I think the youth of this nation really do deserve a chance at trying to prove and trying to really help empower others. So that's my piece.
Thank you. Let me if there's some questions from the audience or questions from Twitter.
I'm following questions from Twitter, so there's been a number of them.
Is it on, the mic?
Yeah, it's on. Yeah.
So let me start with, I'm building on that conversation we were just having. I'll start with the conversation we were just having.
It's not on?
I will start the conversation we were just having. From 100 Million Healthier Lives, we believe we need unprecedented partnership across sectors. What are some unique partnerships we can make?
The most important partnerships, I think, are going to be between communities that are affected by all of these things we're trying to solve and the people who are trying to solve the problems. So the most important partnerships are whenever we're at a problem-solving table to look around and say, who is not at this table who has an interest in this proceeding? And then not to just try to represent their interests, but to bring them to the table.
Yeah, the one thing I was going to start off by saying exactly what Kamara said, which is making sure that we include the people that are affected. One of the things I have seen sometimes in a lot of local governments is partnerships between folks who disagree. Sometimes it's easier to disagree when you're in smaller communities because there is less visibility. But sometimes when people have different views and they end up clashing and then coming together, the solution I've found presents for unique and interesting insight from both ends. So I would add on to what Kamara said, that the idea of including the people that are affected would be particularly important, but also making sure that you bridge the lines of understanding between red or blue, green or yellow, black or white, or whatever divisive line one might think of.
You know, go ahead. No, go ahead.
No, so I've been scribbling
Go ahead. scribble.
frantically. Because I wanted to also build on what you said about involving youth. So I'm going to jump out there and say that most of us are not doing succession planning at work or anywhere, right? And involving youth is how that's succession planning, to bring people up behind you and train them and the like. And so I need to really applaud our association, the APHA, because even articulating a goal that is a generational goal is something that we don't do in the United States typically, because we aren't really thinking about even our children's health typically. And many American Indian nations think about 7 generations hence. That's succession planning. When you think about the environment, 7 generations hence. When you think about, educational opportunities or whatever. So thank you for lifting up the importance of involving youth. We should all take that to heart and think in our own lives, in our churches or wherever we are, in our communities, we need to start involving youth, because that is how you touch the next generation. We're so selfish that we just think, okay, well, when I'm dead, that's gone, the story's over. And if we start having a kind of generational, healthiest nation in one generation, 7 generations hence, we will protect this world and our society and our people much better.
And just to add on to that, I think it was so easy for this week's theme for the APHA to kind of have a theme of just celebrating previous successes, because there have been so many in recent years. But I really want to applaud this organization for recognizing that we're kind of looking ahead to the future and looking ahead at 2030 and being, how can we really make the U.S. the healthiest nation? And I think that is a wonderful theme, and I think that youth definitely have a place at the table for that theme as well.
Thank you. I wanted to have one of our critical partners speak. So Lee Fisher, CEO from Cities.
My question has been touched on, but I'll just offer a different perspective, and that is, when you bring a cross-sector team together to advance the health of a city or a county or a tribal nation or the nation itself, very often public policy makers react more positively when you see it through an economic lens. So my question is, have you given any thought, or do you know of any strategies or approaches that have worked so that public policy makers can understand why having a healthier nation makes us a more economically prosperous nation?
So I have to admit that I do not like to go there. I do not like to quantify people's lives or people's value on that, but I recognize that that is a strategy that has worked in this society.
Well, I can give one example. So, someone you may know, and I've used this example a lot, and so I apologize to my good friends and colleagues in New York City for this concept that they've really embellished and really made popular. But they've got something called the green card experiment in New York City. And of course, everyone who's been to New York is very familiar with the little food vendors on the corner. And we won't have the discussion today about whether or not what they sell is healthy food or not, but I can tell you it's good.
Right, that's exactly right.
Very, very good.
That's right.
But they had a big debate about food deserts in the city. And they were looking for meaningful solutions to food deserts. And so they decided to expand, I think, about 1,000 licenses for new food vendors. But they could only sell healthy fruits and vegetables in communities that were underserved with fresh fruits and vegetables. So they created a new business model and provided a public service. And they got rid of a couple myths. I saw the evaluation of the project, and a couple of the myths. Myth number one was that underserved populations and low-income people would not buy fresh fruits and vegetables. All right? Turns out that folks in underserved communities like their vegetables fresh and their vegetables frame and their vegetables tasty, like everyone else. And of course, they will buy fresh fruits and vegetables if you offer fresh fruits and vegetables. Of course, the other thing is they have to be affordable. And so affordable fresh fruits and vegetables through this project makes a lot of sense. Now, it's a great model, and my understanding has been very successful. But it's not, applicable to every community. But, for communities that, that can't do the carts, folks have bought refrigerated trucks and vans to take it to other communities. So I know there are other communities in the Midwest that have looked at this model and thought about trying to do it. The point is that it creates jobs for folks, and it creates access to foods and fresh fruits and vegetables, and begins to change the model of food deserts in communities. Saw another one when I was in New Jersey, and went into one of the community bodegas, a little small community store, and the question was, can you sell, and from a business perspective, salads and fruit cups? And it turns out, yes, you can. What they needed was someone to help them buy basically a chiller, refrigerator, in this small store. And the salads and vegetable cups are flying off the shelf. I think they're $1 or $2. They're flying off the shelf. Now, we have to get that particular store to stop selling tobacco. They're still selling tobacco. But here's a place where there is an economic model to try to build them a revenue stream on something other than, high caloric, high fat, low nutritious foods. And hopefully at some point that, they'll be able to see the economic tipping point where one can then go in and have a reasonable discussion with them about not selling tobacco. So those are a couple models, Lee. Please, Chair, but you need to go to the mic or. Yeah, she's got a mic for you.
The green carts in New York, one of the key things about it also was that if you got that license, you had to accept SNAP. You had to accept the SNAP benefits, A, and B, locate in strategic places, including outside of Head Start programs in the evenings when people would be picking up their children. So you truly are creating accessibility financially and in terms of geographic access, just to elaborate on it. Because when I was at Kellogg Foundation, we put money into that program that you're talking about, the green cards. And so it was really a viable way to do exactly, and encourage farmers to bring their foods into the cities, into the Bronx, and into Queens, and into those communities that had the food deserts. Yeah. So it was a phenomenal model. And then another model I wanted to share was in the New York Times a few months ago, where they showcased a superintendent in Jennings, Missouri, which is a community right next to Ferguson. And she was a superintendent of schools, and she single-handedly brought a shelter, because she was having a lot of kids that were missing school, right? We talk about education being a significant strategy. And so she went about the business of removing those barriers that kept kids from not excelling in school and not being present to be able to excel in school. And homelessness was an issue. Access to food was an issue. She had a shelter located very near, it was in the New York Times, a shelter located very near the school, so that the kids that from her school would get preference of being housed at that shelter. Food was an issue as well. Access to uniforms, it was a uniformed school district, et cetera, et cetera. She removed single-handedly, with partnerships, but it was her vision that said, I want kids to be able to complete school, and I'm going to remove those barriers. So there's an example, because it required housing. It required, a number of the local industries in that community to come together to remove those barriers. So we have some pearls out there.
Thank you. Microphone on my left.
Hi, my name's Julie. I'm a current NPH student at GW. I was really struck by what you were talking about with, some schools they offer yoga and these healthy options, and some schools don't. And I think that's interesting, because I think then at a young age you're telling children who are at these schools with healthy options, you deserve it. You have a right to prioritize your health, and you have a right to prioritize preventive health. So I was wondering if, as you're looking into these healthy, like planning programs for communities in the future, it's one thing to say, welcome to the table, here's food on it, you're part of the conversation, sit down and eat. But do you see any pushback from community members once the access is there, with them thinking that they deserve it, or without them realizing that it's for them and that they can use it?
Yeah. So if I'm understanding your question correctly, it is if when you create the actual access point, will people actually take advantage of it? And it reminds me of this experience I had when I was in the federal government. This was particularly around Medicare Part D. And many times when people would open up these very fancy things to try and recruit people and get them to sign up for these things, and people wouldn't show up because they had never had any experience with a particular institution. In fact, in some of our finest branded huge hospitals that have all kinds of national rankings, many people from those low-income communities will drive past that shiny hospital to go to the hospital that has a history of accepting them in the past. And I've been in many of those institutions and seen people do that. And so what you learn from that is communities have a memory, and they have a track record of experience, and they remember the kinds of people who are there for them through tumultuous times, and it might be 50 years ago, it might be 70 years ago, and kind of understanding that history. So I think part of what the solution is understanding the history of each location, understanding the dynamics of the community, and understanding where people feel comfortable to be able to either access a service, whether it be a service around a government program or even a service around their own health. And sometimes it's not just about building the shiniest building or putting on the shiniest badge, but being able to have people understand that that place is actually for them and that they feel comfortable there.
Let me, John, before you say, let me just say one thing about kids. I've got 2 grandkids, and I got to tell you, it's wonderful watching grandkids, because you, as a parent, you watch grandkids differently than you watch your kids for different things. And I got to tell you, one of the things that I certainly have observed is they don't miss much. And the assumption that they don't know in an environment in which there's 24 hours a day, 7-day-a-week news cycle, TV, radio, access to communication, and they're talking to their friends about stuff. And my grandson came home talking about a cartoon character, excited about this cartoon character that he had never seen. And then when he saw it, he was really excited. But he had never seen it. And so the idea that because someone goes to a school that doesn't have the same services or food choices or other choices as someone else, that they don't know the difference, is a fallacy. They absolutely know the difference. Because we're clearly in a globalized world now, in globalized communities. And so they know. And it has to do a lot to their belief of self and self-esteem, et cetera. And so again, it's part of this, the idea of valuing everyone. We need to sometimes step back and think about things through their lenses. Thank you for that question.
Sorry, just to jump off a point that was said earlier about understanding the cultural histories of communities in which we serve, I think that brings up a really good point about recognizing the value of cultural competency. So often we like to think of the communities that we live in, or even the nation as a whole, as this giant melting pot. I've heard that analogy a lot. And I think that might be the wrong analogy to use, because that means that everyone's cultures just kind of assimilates into this big blob, and it's just kind of gray. I think a more appropriate analogy would be to recognize that the rich cultural diversity that's found in our communities and in our nation is more like a tapestry in which it's we recognize the differences and we celebrate those differences. And so I think it's important when we serve in communities or we're trying to pass policies to recognize the cultural diversity and practice cultural competency as well.
And I wanted to pick up on this very rich conversation by first offering my definition of health equity, because it talks about partnership, it talks about all of these things, and then talking very briefly about societal barriers here in the United States to achieving health equity and like what we need to do. So when I talk about when I define health equity, I ask, what is it? How can we get there? And how is it related to health disparities? And I define health equity as assurance of the conditions for optimal health for all people. And this is actually slightly different from the Healthy People 2020 definition, which is assessment of they say health equity is attainment of the highest level of health for all people. And I agree that's our goal, but what bothers me about that is, what if we hit it last Sunday, are we done? And I'm quite clear that health equity has to be a process, it's not an outcome. And which process? The process is assurance, which is actually one of the 3 core functions of public health identified by the Institute of Medicine, along with assessment and policy development. And assurance of what? Of the conditions for optimal health. So that's when you get all of the partnerships in. That's where you get the housing and education and transportation and immigration and justice and all there. Assurance of the conditions for optimal health for whom? For all people. How do we get there? Achieving health equity requires at least these 3 things. The first is valuing all individuals and populations equally. We keep coming back to this notion of societal valuation, but that is key. The second is recognizing and rectifying historical injustices. So I was so happy, Dr. Graham, you talked about history and the role of history, so we'll come back to that. The third is providing resources according to need, not equally, but according to need. Because actually the difference between equality and equity is that equity recognizes history, historical injustices, and it recognizes real differences in need. How is health equity related to health disparities? Health disparities will be eliminated when health equity is achieved. Health disparities is about the outcomes. Health equity is all that came before. Now, the societal barriers that we have to achieving health equity, like, there are a lot of smart people in this room who are talking all this talk and trying to do this work. We have 3 huge things that we have to tackle. The first is that we are ahistorical as a society. We act as if the current distribution of resources and risk is just happenstance, right? And that things have always been the way they are, and that structures and systems are not modifiable. They're immutable. The second is that we have a very narrow focus on the individual. So we don't have the sense of we're all in this together or any of that. We don't have a sense of collective efficacy or interdependence. And when you are so focused on the individual, the systems and structures become invisible or irrelevant. You would rather spend money trying to change the genome than change the huge structures and societal barriers and facilitators that are in our society. The third huge thing is that, and some people might be surprised when I say this, but what I describe as the myth of meritocracy. Our American story goes something like this: if you work hard, you will make it. Now, clearly, most people who have made it have worked hard. Not everybody who's made it has worked hard, but most people who have made it have worked hard. But there are many, many other people who are working just as hard or harder who will never make it because of an uneven playing field. And all of these systems of structural inequity, especially racism, are key in creating and maintaining that uneven playing field. So when we think about one generation, when we think about the babies that are born, do we really think that 2 babies are born with equal potential, or do we think they're born with equal opportunity? If you think that 2 babies are born with equal potential and then they grow up with uneven outcomes, you have to look at systems and structures to figure out what's going on and how you're going to improve things. But if you think that people are born with equal opportunity, and you see uneven outcomes, then this one is either inherently inferior or lazy or stupid. So one of the things, I keep going back because it's such a brilliant vision of like your life and going around to states. What you did, you had the opportunity to burst through bubbles. Because your family kept putting you in one bubble and another, you had the opportunity. All of us are traveling around in our work and school and community and our kids' school and all whatever bubbles. Some of the bubbles are thick plexiglass and some of them are thinner. But what you had the opportunity to do by seeing different schools is to understand your common humanity and other people's common humanity in different circumstances. And what I think that public health needs to do, and all of us need to do, is create opportunities for us to all burst through our bubbles and experience our common humanity, to understand that there's somebody just across town who's just as funny, kind, smart, hardworking, generous as we are, who lives in very different circumstances. When we start doing that, we will start asking the why questions, and we will all be urgently engaged in trying to achieve health equity.
There are several questions from Twitter recognizing that this is a political year and a presidential campaign year. And the questions are completely nonpartisan, but it really is, what should the conversation be at that level? What policies would we like to see leaders talking about to address the issues of equity and disparity and social justice and social determinants?
You know, certainly, I think speaking for APHA, I can tell you for sure we would love to see Congress investing more in broader efforts around the social determinants of health. That means continuing to support the Public Health Prevention Fund and the community-based interventions that they have been supporting, fully investing in the community task force, preventive health task force, the clinical preventive health task force, addressing climate change as a threat to human health, doing some very aggressive things around tobacco. I would love to see the age 21 nationwide. I would love to see the Congress ratify the Framework Convention on tobacco. I would love to see tobacco removed from the TPP agreement, as we've all advocated for, at least the public health community. I think the challenges we have, of course, are that all politics at the end of the day is local, and getting to the point where policymakers are thinking broadly about things upstream and maintaining some sustainability around public health. So I just was at the Center for Disease Control and Prevention on Friday at the Zika Summit, you know, so it's our newest emerging infectious disease. And it was very clear in talking with policymakers that were there, health officers that were there, people that run mosquito programs, the fact that we've had, and that we've just totally destroyed our environmental health programs in the country. The funding cuts have just pulled the rug from under the programs, so that, you know, we don't have great environmental programs. We see this in Flint, and that's the tip of the iceberg. I mean, all of our cities are getting older, and we have all the political issues there aside, the decay in infrastructure in our nation. It's our water systems, it's our approach to clean air, it's our bridges and infrastructure. I saw an article the other day that one of my staff, I think Dr. Wright, sent to me, where the current Secretary of Transportation was talking about the need to begin using more dollars in building infrastructure. And this also goes back to your question, Lee, about jobs and economic development. So as our nation begins to embark on a revitalization of our infrastructure, which we're going to have to do, because otherwise things are going to just start falling apart from under us. We've got to think a lot about how we build roads and how we build expressways, how we rebuild them. We have to think about, why is it that people talk about those people on the other side of the tracks? Well, they're not on the other side of the tracks by accident. Those roads were built very strategically to divide communities. Some of it was because that's what the cheap land was. Some of that was because of the engineering and topography, for sure. But as we rebuild communities, we've got to begin thinking about how we build those communities in such a way so that our kids can see the school and also get to the school, but don't have to get on a bus to drive to the school because of the way we've designed the transportation community and the roads for the convenience of the cars and not for the convenience of people, as an example. And by the way, when we do that and putting people back to work, you know, there's an enormous, and we're going to spend the money anyway, so let's do it in a way that improves our health and gets us from point A to point B.
Well, so I have, yes, pay a living wage, living wage. I sort of divided into breaking down barriers to opportunity and building bridges to opportunity. So the breaking down barriers to opportunity, so let's abandon this ill-conceived war on drugs that is disproportionately incarcerating so many black and brown men in our prison system. Let's, in terms of bridges to opportunity, strong early childhood education, strong social security around families, even, you know, building the infrastructure, jobs programs like back, you know, after the first big crash, you know, let's have a works program that can employ people. And then even on the health side, there's an old model called community-oriented primary care, which was where a health center took responsibility for the health and well-being of a geographically defined community, so that they weren't just trying to take excellent care of the people who made their way to the door, but they were also trying to address unmet and even unrecognized need in partnership with community leaders. And it involved not just, well, a big part of it was the hiring, training, and deployment of community health workers, which is a jobs program. But it's not just to do patient navigation, but to identify community risk and assets and do community education, all of that. What if we took that as a model that would represent the marriage between public health and medicine? So lots of ideas.
You know, my answer is probably way too personal, but I had a kid not too long ago, actually two, in rapid succession, which has been painful. And my view of what's needed for these 3- and 1-year-old little bundles of joy to keep us up at night is what's changed my view of kind of politics and politicians and the future. And a lot of it has to do with when I look at my sons and I see that I want for them the best in the world and all the kinds of opportunities that anybody else could have. I then get saddened by people who feel the same way but are not economically advantaged to be able to achieve and give their kids the same thing, because we're going to give our kids everything we can, and I know most parents would. And so when I sit back and I think of kind of the politics and the dynamics and the kind of where we are as a country where we need to be, I think I would change the discussion to say to each candidate, each campaign, you know, what would you do to give everyone in this country the best opportunity they could have to live the longest that they could be and be the most successful they can be, and not think of any other strategy other than that, because I think that's what we all want for ourselves now, and we all want for our kids in the future.
Thank you. I'm going to take one more question from Twitter, and then I've got a lightning round of kind of closing questions from each of our individual panelists. Dr. Poland.
The question from Twitter was, what role will technology play in all of these issues as we're moving forward?
Let me put you.
Yeah. So we know our foundation, actually, really, it's Elise who's sitting here in front of us and all her brain power, and I was taking all the credit for it, has really been dedicated to this issue of how can we use technology to serve underserved communities. So we're trying to fund projects that have little to do with technology at being advanced for just generic advancement, but how do you apply it to poor and underserved communities? And one of the things I've learned from this process is that we have a distinct emphasis in how we deploy technology towards a worried well right now, which means that I look at my wife. My wife is not just a picture of beauty, but of great health. And she has the thing around her wrist, she has the thing around her neck, she has the thing, and when she walks into her house, thing goes off, and she's the person who needs it the least. But those are the people that currently I think our technology, and it's very effective for her, but our technological developments are directed and applied towards that population. And so we want to see it directed to those who need it the most. And we do see where something as generic as connectivity through social media can cause a wave of change, sometimes good, sometimes challenging. But we do see sometimes even in organizational structure within a lot of poor and underserved communities where people come together through social media and the kinds of tools that those things can afford. So we're not there as a country yet, but I think we can achieve amazing things if we started to slide the deployment of the kinds of technology that empower people towards those who need it the most.
Ms. Linscott, why don't you, I know you've done social media, why don't you talk to us a little bit about that?
Sure, yeah. So I think, technology can be an incredibly powerful tool, particularly that of social media. We all like to think that social media is a entirely new concept and it's never been heard of before, at least, it just sprung up in the last 20 years, when in fact it might just be a remediation of prior existing media. But I think with social media, it's very important to recognize that you can reach a large number of people relatively easily. So with the Not a Replacement campaign, what we did is we had youth take selfie statements and they uploaded it to social media. And so that did one of two things. It allowed the youth to be engaged in an advocacy effort, and it also allowed their friends and their followers and their the likes to their pages, all of those people, all of those individuals and their groups got to see that message. So I think when we're talking about technology, the idea of using it as a platform for education and using it as a platform for engagement, particularly that of the youth, can be very important. Because with that Not a Replacement campaign, over the course of the first year it was out, we had nearly 5,000 youth in Florida do it. And then in Kick Butt's Day, for that second year, we had even more youth take part in that initiative. And so I think the power of social media and harnessing that can be very, very, very helpful when thinking about educating the population.
Thank you. Let me do maybe a little lightning round here. If I could maybe just ask Dr. Jones, if you would talk a bit about, kind of as your closing statement about getting our affiliates. We have affiliates in every state in the nation, the District of Columbia and Puerto Rico. If you could talk about engaging them in the work of public health that we're doing, and how they might get involved in some of the work of the association, including this kind of Healthy Cities activity.
Well, that wasn't what I wanted to end with. So I could do both? I'll answer the question and then I'll pivot, okay? Well, I think first of all, I have traveled to just 3 of the affiliates so far of my 18, because most of the meetings that I go to, the public health meetings, they will be next week and the week after.
But they're all listening.
I know, I mean, there's and then in September and October. But what I'm struck by is that the members of the affiliates are very engaged in not only the work of public health, but kind of the state-level legislative efforts of public health. And I think that that's just where we need to have more liaison and partnership, if I will. And I think that the American Public Health Association does a great job with affiliate affairs in supporting the affiliates and connecting the affiliates. One of the challenges as I'm going around, because as I said, I've announced this national campaign against racism, one of the things that I'm letting people be aware of is that there actually is an international anti-racism treaty. You talked about the Tobacco Convention. There is something called the International Convention on the Elimination of All Forms of Racial Discrimination, which was adopted by the UN General Assembly way back in 1965. ICERD, I-C-E-R-D, if you want to tweet that or Google it later and get there. And so, I'll ask the people sitting here, how many of you think the U.S. signed this International Convention on the Elimination of All Forms of Racial Discrimination? Like most people think no, but we did. We signed it in 1966. But the key there is you can sign a treaty, but if the Senate doesn't ratify it, then it doesn't. So how many of you think that the Senate ratified this treaty? They did. The U.S. Senate ratified the treaty 28 years later, so in 1994, which means that today, we as a nation have international treaty obligations to do right under this treaty, which includes our State Department writes periodic reports to a UN committee. The committee gets gets that report plus as many other shadow reports as people want to send in. So APHA could send in a shadow report. Any of our state affiliates, any organization could send in a parallel report. At the last consideration of our report in 2013, the committee had the U.S. 69-page official report and 82 parallel reports. They considered all of that, and they sent back to us in September of 2014 their 14-page concluding observations, which goes something like this. Dear United States, thank you for your report. We remain concerned about racial segregation, disproportionate incarceration, the achievement gap in education, differential access to health care, disproportionate incarceration, on and on and on and on. And so they not only remain concerned about, they make recommendations on each of these topics, and they also recommended for the first time that the U.S. establish a national action plan to combat structural racial discrimination. So not only is APHA interested in a national campaign against racism, but the U.S. has been instructed that we need a national action plan to combat racial discrimination. They also say, dear United States, you need to let your people know about the existence of this treaty. So every time I have an audience, I do my part, which is what I wanted to close with. But when you talk about the affiliates, honestly, it's a 14-page concluding observation document, and I actually recommend that all of our state affiliates and all of our partners across the land get that 14-page document, look at it, because there's at least 1 or 2 paragraphs that can be a basis for community mobilization and action, whatever area, whether you're in housing or transportation, wherever you are, we're a criminal justice system, there is something that speaks to you that we have international treaty obligations to address.
Ms. Linscott, closing comment?
Just closing comments. It's an honor to be here again. Preparing to study for that test, thinking about that. But I would just like to close with, I think, and I said this earlier, I think the power of the youth voice is so important, and fostering that youth and adult relationship and partnering with them in communities for community projects of all scopes and sizes, I think is quite important. We had a Kick Butts Day event around last week, and for those of you who don't know, Kick Butts Day is a national day of youth activism in which youth advocates across the nation advocate for tobacco-free policies. And this year's Kick Butts Day was a huge success. We had events not only around the U.S., but in Canada and around the world. And I think fostering that passion for healthy behaviors is so important as we work ahead to meeting our goal in 2030.
Thank you. Dr. Graham.
I kind of alluded to this before. I'm around kids a lot these days, little kids. And their excitement is so infectious, and it makes me get passionate about things that we need to be doing and things that we should be doing to create a better future. As we start kind of National Public Health Week and we start talking about this challenge that we're kicking off and all these different things, there are things that other foundations are doing some amazing things on the culture of health with Robert Wood Johnson and all these great things that Kellogg is doing addressing racism and all of these things that are occurring across our country. Let's get excited about this and start promoting and getting other people infectiously excited about getting this. Let's tweet it. I don't know what these young kids do nowadays. That's whatever these kids guys do. Let's Twitter it. I heard you say pound as opposed to hashtag, and somebody told me that's a sign of age. He said pound instead of hashtag. He said pound it. But let's do all the kinds of things that we need to do, even if just for today, to be genuinely excited about how we can make a change. Because I think that if we aren't excited, if we aren't the group that's driving this excitement, if we aren't the group that is going to, tweet something to oblivion or whatever we got to do around challenging racism, around challenging inequities, around moving forward, even just for one day, I would like us to just be excited about the kinds of things we do. If not for this day, let's do it commit to doing this for the rest of National Public Health Week. If not, let's make this National Public Health Year. But more importantly, if there's anything I want us to try and do, is to be able to take all the energies that we're hearing, all the passion, all the wisdom, especially from Kamara and others, and generate some real excitement around how we can address the social determinants of health.
Well, thank you. Let me also just close, talk a little about some of the other things that are going to happen this week. There's actually, for those of you who are in the Washington, D.C. area, I think there's from 5 to 7 at APHA headquarters at 800 I Street. There's a healthy happy hour. Healthy happy hour. Is that today? That's today from 5 to 7. Sorry, I take that back. It's Wednesday, right? Wednesday. Tuesday, tomorrow, there is a webinar on the Public Health Authority on drinking water, which I would commend that to you. It's at 1 o'clock Eastern Daylight Time. We will have 3 amazing speakers there, including Dr. Hannah Atisha, who is a pediatrician that found the elevated lead levels in the children in Flint, Michigan. Also on Tuesday, I'll be speaking in the Massachusetts Medical Society on firearm-related safety and violence. Wednesday, we're going to have a Public Health Week Twitter chat. I think it's from 2 to 3. I'm also speaking at the University of Pennsylvania for their Health Equity Week. On Thursday, I think, Dr. Jones, you're going to Puerto Rico to the Public Health Association annual meeting. I do not get a chance to carry her bags to that meeting, but I wish I could. I mentioned the happy hour on Wednesday. And then on Friday, from 2 to 3, we're having Student Day Town Hall, which is a Google Hangout, where we've are honored to have the United States Surgeon General, who will be hanging out with students on that particular day. So with that, I want to thank everyone for being involved in National Public Health Week. I want to thank Kim and her staff for all of their hard work in pulling this week off, which is just beginning. Yes.
Before you close, so it's not just what we're doing. There are many, many National Public Health Week observances happening across the country. How should people let us know about what they're doing?
Yep. So if you go to our website, at the National Public Health Week website, there is a partners box, and you can put in all of the events that you're doing this week on that website. It is, I think, an enormous opportunity for us to capture. We know that there are already many, many, many people that are involved in capturing activities around the nation on this week. And thank you very much for asking that very important question, because that's the way for people to get involved. And this is a week for us to educate, motivate, celebrate. And I think as I close, I want to just take another plug for those cities that are eligible to get involved and to consider strongly being part of the Healthy City County Challenge Prize. That is small to mid-sized cities and tribal communities are eligible to apply for that. And again, I just want to publicly thank the Aetna Foundation for their foresight and wisdom, and Garth for being a critical partner, the folks from NACO being critical partners on this, and of course our friends from CEO from Cities. Thank you very much, and everyone have a wonderful day.